everyone. I'm Sam Carpenter.
And I'm Alex Peterson.
I'm Erin Stone King.
And I'm Michelle Stover.
And this is our presentation, Patient Outcomes with the Use of Point of Care Testing in Acute Care Sepsis Patients. The organization we chose to use is a rural facility in Fairmont, Minnesota. And here you can see the mission, vision, philosophy, leadership, and alignment with EVP. It's a Mayo Clinic facility, and Mayo Clinic is very ingrained in evidence-based practice, and they are striving to deliver the best outcomes for the highest quality service through a dedicated effort of every team member. When we analyze the organizational readiness of an organization, there are a few pieces that we need to examine: stakeholders, barriers, and facilitators. Some of the stakeholders include patients, healthcare providers, social workers, researchers, laboratory staff, nursing personnel, advanced practice providers, physicians, and hospital administrators. Here we have some barriers, include staff adapting to the change, lack of knowledge using the equipment, staff resistance and fatigue with changed processes, timing of the process change, and then some of the facilitators are leadership from management, clinical leaders, educators, and administrators. Background and significance of the problem. So, why focus our attention on sepsis? Well, sepsis and septic shock are major health problems that impact millions of people, causing major organ dysfunction in response to infection. According to the CDC, each year about 1.7 million adults develop sepsis in the United States, and of those, 350,000 end up dying or on hospice post-hospitalization. Early recognition is key to minimizing end organ damage and death. Lactate measurement is the most widely used diagnostic tool. And the Center of Medicare and Medicaid Services incentivize healthcare organizations to meet SEP1 core measures. The SEP1 core measures focus on timely sepsis recognition and subsequent prompt antibiotic and fluid resuscitation administration. When facilities meet timing targets and benchmarks, they are financially rewarded through CMS.
Step 0 of our process to this project is our clinical inquiry. All of us work in rural healthcare, and we were wondering what we could do in a rural setting that would close the gap between time of presentation to the healthcare setting and diagnosis of sepsis, which is what led to us questioning a point of care lactate versus a traditionally drawn benchtop lab for diagnosis.
Which that is what led us to our PICO question, which is an intervention question. So our PICO was in acute care patients with suspected sepsis. How does the use of point of care laboratory studies compared to current practice affect patient outcomes within 24 hours? So our focus population is the acute care patients, such as those that present to the ED or in the ICU or in the NICU, who would present with symptoms of sepsis. In the intervention we focused on was the point of care laboratory testings devices such as the iSat at the bedside, which could be used to obtain lab values that can indicate sepsis, such as lactic acid levels in comparison to current practice, which may include the benchtop laboratory testing. And we also looked at patient outcomes, like what are the outcomes when point of care is used? Do mortality rates change? Do the lengths of hospitalizations change? So the time frame that we chose is 24 hours because as we noticed in the research, treating sepsis within a few hours is that gold standard. So it's crucial to recognize signs of sepsis.
When we were searching for literature to review for this project, we used a list of keywords and phrases, mesh terms, which led us to a broad number of articles, which in the next slide will show our Prisma table. And as you can see, we went from thousands of articles, narrowing it all the way down to 12 that we kept through a critical appraisal process using rapid critical appraisal forms.
So in step 3 of our process, we did an evaluation and summary. And then you can see here, we have our first keeper article, which is number 1, keeper article number 2, and number 3, and number 4, number 5, number 6, number 7, number 8, number 9, and 10, number 11, and finally number 12. The other portion of step 3 was our synthesis. The synthesis of evidence focused on evaluating the effectiveness of point-of-care testing for sepsis detection, particularly in rural emergency departments. It involved using various evaluation tools, including levels of evidence, effective interventions, and emerging themes. The evidence ranged from high-level systematic reviews, level 1, to clinical practice guidelines and quality improvement projects, which was level 6. The body of evidence included a mix of studies, designs, with the majority being level 4 and level 6. Despite lower evidence levels from studies, they still provided valuable insights, particularly in rural settings where point-of-care testing is commonly used. One level 1 study, a systematic review and meta-analysis, explored the role of machine learning in sepsis prediction, offering insights on how data from point-of-care testing could be used for faster diagnosis. Key interventions include using point-of-care devices to measure lactic levels, which reduces wait times and improves outcomes for sepsis patients. Studies indicated that bedside point-of-care testing improves timelines and accuracy of labs, leading to faster diagnosis and treatment. While some studies found no difference in timeliness between point-of-care and traditional testing, most supported the benefits of point-of-care testing in reducing mortality rates. Other successful interventions included point-of-care CRP testing to predict respiratory illness and point-of-care procalcitonin testing for bacterial infections. Point-of-care testing was linked to shorter wait times and decreased length of stay for stable patients in emergency departments. Studies also showed that serum lactate levels were associated with mortality in sepsis patients, emphasizing the importance of rapid lactate measurement for timely interventions. Additionally, point-of-care testing was found to enhance adherence to sepsis protocols, leading to improved patient outcomes and lower mortality rates. Emerging themes from the literature highlighted the rapid turnaround time of point-of-care lactic testing and its association with reduced mortality. Other indicators of sepsis, such as lactic, CRP, and heparin binding protein, were noted as valuable predicting sepsis or its progression. Point-of-care testing, especially in rural areas, proved to be beneficial for facilities with limited laboratory staff, as it provided fast and accurate results.
The Iowa model revised was chosen by Briarcliff University for this EBP class to be used. And so the steps for the Iowa model include triggering issues and opportunities, state the question or purpose, form a team, assemble, appraise, and synthesize the body of evidence, design, pilot, and practice the change, integrate and sustain the practice change, and disseminate the results. So, as we identified in step 0, we identified triggering issues and opportunities identifying that there's a gap in care as far as diagnosis of sepsis when benchtop labs are used. The purpose of our project is our PICO question in acute care patients with suspected sepsis. How does the use of point of care laboratory studies compared to current practice affect patient outcomes in 24 hours? A team of 4 graduate students, myself, Sam, Alex, and Michelle, along with Mayo Clinic Fairmont staff to implement the new change would be formed. We have reviewed how we would assemble, appraise, and synthesize the body of evidence. And in the coming slides, we will discuss piloting the practice change, integration, and dissemination of the results.
So in step 4, we have our evidence-based recommendations. Based on the evidence, it is recommended to implement point-of-care lactic testing in rural emergency departments to improve patient outcomes, particularly for sepsis detection. Although a comprehensive bundle with multiple point-of-care tests, including lactic, CRP, glucose, and procalcitonin, is ideal, even a single point-of-care test like lactic can significantly improve early diagnosis and treatment of patients. This approach would complement traditional lab tests that take longer for results, ensuring timely interventions and better patient care.
Implementation plan for this project would include writing a new policy and procedure to be put in place at Mayo Clinic in Fairmont. And then there would be education for staff for proper use of the new point of care testing devices. And our third step would be identifying methods to record measures so that we can analyze data properly.
Another part of step 4, the implementation. What outcomes are we going to be trying to measure during this? The project include data that will be collected from the electronic medical record, and these include rate of hospitalization, sepsis-related mortality rate, and 3 data points that make up the sepsis quality measures, which include time to lactate, time to antibiotic administration, and time to fluid resuscitation. The so what outcomes were identified. These are practical outcomes based on the evidence presented that we could reduce the wait times for diagnostic testing when lactate can be measured at the bedside. Septic patients can be accurately and promptly identified even in the waiting room, which has the potential to improve patient outcomes and save lives. Data will be collected 30 days prior to implementation and averaged. These descriptive statistics will provide for the control within the experimental design. The post-intervention data will be collected at 1, 3, and 6-month intervals. Using multiple time intervals in data collection allows us to identify gaps in the during the implementation and data collection phase rather than simply using a single data point for data collection post-implementation. Once these data points are collected, a paired t-test will be used to compare the continuous variables at each interval against the control data. These include all data points except for the mortality rate. As for the mortality rate, a Kaplan-Meier survival analysis will be performed to compare the survival rate between the intervention and the control group. Oops, I'm sorry. The facility should see a return on investment in the form of reaching improved SEP1 benchmarks as they are financially rewarded through CMS. Currently, SEP is working its way into the hospital value-based purchasing program. Adoption of the program will begin in 2026. However, adopting these criteria now ensures that the facility will obtain reimbursement without delay.
Dr. O'Connell Prasad was our EBP mentor for this project. Key actions in her guidance with us was providing guidance, supporting our professional development, and monitoring and evaluating progress of this project. She was also our leader. She was able to teach and train us on EBP, facilitate hypothetical implementation of this project, and she encouraged reflection and critical thinking throughout the entire process. Recognition and celebration occurred many times throughout this initiative. We celebrated each other's accomplishments and hard work. We were able to meet weekly using a variety of communication platforms, including text messages, Zoom calls. Key moments were development of an online document sharing system that worked for us to be able to collaborate seamlessly on all of our projects.
The
So,
sustain the sustainability plan strategies included regular review of the data being collected and continuing to educate staff. The key players involved in this are going to be the educators that are going to be continuing to train new staff as well as existing staff, and then current staff implementing the practice of using point of care testing for lactate measurements. And then, as with any project, having administrative backing aids in compliance with the staff at the hospital. Step 6, the dissemination plan. The local dissemination plan includes results presented to Briarcliff University Excellence event, as well as at MCHS Fairmont or Mayo Clinic Health System in Fairmont. Regionally, this could be used and presented at MCHS Mankato, as well as other NP conferences. Nationally and internationally, we could identify journals that the EBP could be submitted for publication. Some aha moments that we had while we were working on this project was when we figured out the difference between the EBP and research. That was kind of a aha moment for most of us. Connecting theory to practice, so being able to think about projects in a way that aligns with what we're doing as nurses and as students in the clinical setting. It also helped us reframe our perspective towards EVP in our daily work as students and nurses. These are our references and our summary slide or elevator speech. Thank you.